So now we are on to technology overuse, right? So you may have thought after last video, oh, okay, he said he was going to talk a lot about moral hazard this video. But after the intro, he didn't talk that much about it. Most of the stuff about prices was due to, he was talking about the CPI and improvements in medical treatment, and maybe he's not going to talk about moral hazard. Well, I got you, because now we're returning to moral hazard, and you will be sick of hearing it by the end of the video. By the end of this course, by the way, every time you hear the words moral hazard, you will want to stick your head in the sand to avoid that term, because moral hazard is going to come up so frequently from here on out. But really, the question is, what are we getting for all this really high healthcare spending, right? So even if it's right, even if prices of medical care, they're increasing, but the price of health may not be rising, and when you hold quantity fixed, the medical care CPI, it's increasing, but it's not going crazy. But healthcare spending is going crazy, right? So even if the medical CPI isn't going nuts, healthcare spending is, which means that quantity is going nuts. What are we really getting for all that new technology, right? Is it worth it? And to what extent is moral hazard driving medical care and technology overuse, right? So, just as a reminder, what is moral hazard? People demand marginally useful but expensive treatments and innovations because of insurance coverage, right? This is ex post moral hazard specifically, right? And that's what we're going to be talking about from here on out, right? Ex ante moral hazard is when, I'm insured, so I take more risks. There's evidence of it, right? Go back to the Rand healthcare study. But ex post moral hazard is the big problem in healthcare, and we're going to start seeing why here. Are we using our new medical technologies efficiently, right? And can technological overuse explain rising healthcare costs, right? Now, concepts to have in mind in previous lectures: medical arms race, right? Hospitals start competing for higher quality care, even if it's only marginally useful, because they know patients aren't price sensitive because they're covered by insurers, aka hospitals buy too much technology because of moral hazard. Right now, in general, technological improvement is always good, right? That's not the case in moral hazard, right? Because people may demand too much technology improvement relative to what they would be willing to pay for if they were footing the bill themselves. And then also, just to have in the back of your mind here, right? We're really going to be talking about the U.S. context here, right? Other countries pay a lot less for healthcare. Is the U.S. overproducing healthcare innovation because of moral hazard? Right? And could that be offsetting the fact that most countries are underproducing because of the free rider problem we talked about last lecture, right? Where at a country level, innovation in medicine is you can think of it as a public good that the U.S. is providing. And so just healthcare economics is complicated. There's a bunch of subtlety to it. One of the subtleties is that, yes, there may be too little innovation globally, but too much innovation in the U.S. And so on the global level, if the U.S. is overproducing and everybody else is underproducing in medical innovation, those are going to cancel each other out here. Now, for the sake of this lecture, we're just going to limit ourselves to the U.S. and see, is there evidence that the U.S. is overproducing? And the answer is yes. From the U.S.'s perspective, there is evidence that the U.S. is producing too much healthcare technology. Now, that doesn't necessarily mean the world is producing too much healthcare technology, because, again, most healthcare companies are making most of their money in the U.S. And so it could be the world is underproducing healthcare technology, but the U.S. is overproducing it. These are two problems that can coexist and to a certain extent may cancel each other out. So let's talk about perhaps the best evidence we have on medical care overuse, and that is the Dartmouth Atlas Project, which very sadly was discontinued a few years ago. But we're going to talk about the Dartmouth Healthcare Atlas, right? It tracked Medicare expenditures across the U.S. We're going to talk about one study that focuses on the years 1995 to 2005. It's looking at medical care by elderly Americans, right? Remember, Medicare is elderly, Medicaid is low income. So this is elderly Americans in their last 2 years of life. They track 9 conditions, things like cancer, diabetes, sort of common conditions that are big health concerns for elderly people, heart disease, etc. They're going to look at the spending in these last 2 years of life, right? Now to give context, 32% of Medicare's budget is spent on people in their last 2 years of life, right? So everybody from the age of 67 and up gets Medicare for free, right? And about a third of Medicare expenses are spent on people in their last 2 years of life. So this is a massively expensive period of time, right? I mean, if you've had a relative in hospice, you know it can get really expensive really fast, right? Those last 2 years where we're sort of depending, especially if you make the decision to try to squeeze prolong life as much as possible, you can prolong life for a few years at an extreme cost. Now, the quality of that life is not necessarily great, right? I saw this with my grandparents where my mom's side, right? My grandfather, he lingered for a really long time. We spent a ton on medical care, and he didn't have the last few years of his life weren't great. My dad's side, my grandfather, he died more recently, and when it came time for him to die, he said, "All right, it's time for me to die." He went into hospice, and when it came time for him to die, he passed away. And so these last 2 years are really expensive, right? So and there's a real question on whether that spending matters, right? So we'll go into the data on this shortly, but if you've seen Scrubs, which at this point you really should just watch the first season of Scrubs just for the class. I'm not assigning it for the record, but you if you're looking for a sitcom to watch in the summer, you have free time. You're a college student. It's summer. You probably have free time. Some of you don't, but some of you probably have free time. Go watch Scrubs. It's great and course relevant. And one of the things Dr. Cox, which is sort of the jaded mentor of JD, the main character, says in I think one of the first few episodes, is welcome to the American healthcare system. You're going to spend an insane amount of time helping people who are beyond saving, right? And so when you find someone who's worth saving, you better give them your all, right? Someone who's capable, sorry, not worth saving, but capable, someone who you're capable of helping, you better give it your all, right? Because so many people you're actually just not capable of helping with medicine. And these, it could be, right, these last 2 years, right, it could be we're wasting a lot of money for no reason, right? So this is a very relevant question. Are we actually getting better healthcare for all that healthcare spending in these last 2 years of life? And to give you an idea of how much this costs, right, so 32% of Medicaid's budget, I assure you Medicaid's budget is huge, and we'll get into that later when we talk about the American healthcare system. But what does that mean in terms of dollar amount? Well, that's an average of $46,000 per patient, and this is before the recent bout of inflation, right? So this is like $50,000 or something today, in the last 2 years of life, right? So the last 2 years of life are costing you the last 2 years of the average American's life, they're spending $50,000 on medical expenses. That's nuts. That's a ton of money. That's super costly. That's costly to taxpayers, right? Because we foot the bill for Medicaid, and Medicare. In this case, Medicare in this case, not Medicaid, right? So these are super expensive, and we should know if we're getting bang for our buck, right? If you spend a bunch of money on your grandfather or grandmother's healthcare, are you going to see a lot of payoff for that? And basically, obviously, that varies from case to case. I'm not giving medical advice. Please don't quote me on giving medical advice. But patients with the same diagnosis can get dramatically different care in different places. And this can cost massively different amounts. And there's basically no correlation between treatment price and health outcomes. So places that are charging a lot more for the treatment in these last 2 years of life don't seem to have better health outcomes. So it's sort of, it's evidence that Scrubs is, as always, an incredible show full of amazing wisdom, and Dr. Cox is right that we spend a lot of time treating people who we actually can't help. So let's talk about the variation in medical spending. So New Jersey, right? The average medical bill in the last 2 years' life in New Jersey was basically $60,000. In Ohio, it was $23,000, right? That's almost 3 times more, right? It costs almost 3 times more to die in New Jersey than it does in Ohio, right? That's a huge amount of variation. Another example, in Miami, Florida, right? It costs $84,000, $84,000 to die in right to spend the last for the last 2 years of healthcare in Miami versus La Crosse, Wisconsin. It's only basically $37,000, right? Again, it's over twice as expensive to die in Miami as it is to die in La Crosse, right? And so variation was crazy even within the same city. So within LA, for instance, the most expensive hospital costs 2 times more than the cheapest hospital, right? Healthcare costs vary very wildly across hospitals. And again, generally, what are we getting from this? On paper, doesn't look like very much, right? There's not much correlation between spending and outcomes, at least for these last 2 years of life, right? So to give a picture of this, and this is, it's a little bit, it's oversimplified, and it's a little, just for the sake of showing, but, right, so we have health expenditures on the x-axis, health on the y-axis. Miami is spending an extra $40,000 on health, on healthcare compared to La Crosse in exchange for the same level of health, right? So why is that? There are 2 theories. One is that these expensive treatments aren't worth it, right? That this is we're prescribing too much treatment, and this is basically moral hazard, right? Where we're spending a lot of money on marginally useful treatments, right? This is the Dr. Cox, this is the Dr. Cox position where why are we treating these old people? They're all going to die anyway. The other theory is that different places have different types of patients that require different levels of care, right? Maybe patients in Miami are less healthy than patients in La Crosse, and so they require more intensive treatment, right? So the reason why healthcare spending in Miami is more expensive than healthcare spending in La Crosse isn't that Miami is more wasteful than La Crosse is. It's that people in Miami are less healthy than people in La Crosse, and so Miami, you need to spend more money the people, like the conditions are more severe, and so people spend more money in healthcare in Miami than they do in La Crosse. And so to evaluate which of these theories is more likely, we're going to look at the health production function, or the HPF, and that's going to be a plot of the relationship between the expenditures and the maximal level of attainable health, right? So, it's going to be increasing, right? So as you spend more, you're going to get your maximum level of attainable health increases, but it's going to have diminishing returns, right? So again, this is going to be a classic, right? It's going to have that classic shape. It's going to look like this, right? Your first few dollars of healthcare are going to be way more efficient in improving your health than your millionth dollar in healthcare is, right? Going from $0 to $1,000 of healthcare spending is going to have a much bigger impact on your health than going from $1 million to $1,000,000 of healthcare spending, right? If you're already spending $1 million on healthcare spending, that extra $1,000 isn't going to make a big difference. But if you are at $0 of healthcare spending, that first $1,000 is probably going to make a big difference. So whether Miami's higher expenditures are wasteful depends on whether Miami and La Crosse share the same HPF. Now, before I'm going to use these graphs to sort of illustrate, right? So there's 2 ways you can think of being wasteful, right? One is you're too high up on the health production function, where yes, you could be spending this much on health, but it's inefficient to spend that much on health. You're spending it efficiently, right? You're not wasting money, right? You're getting the maximal level of health you can given your expenditures if you're on the health production function. That doesn't necessarily mean that's where on the health production function you should be. If you are, what we're talking about here is being below the health production function. And being below the health production function means you are being wasteful, right? So in this picture, Miami is being wasteful because for the amount they're spending, right, they could be here if they were being totally efficient in their healthcare spending, right? So if Miami was efficient, they'd be up here. Or if they if they're happy with their current level of health, they should be where lacrosse is. And if they want to keep their current level of spending, they should be on the health production function. No matter how you slice it, Miami is being wasteful in this picture. But it could be, right, maybe lacrosse and Miami have different health production functions, and both are actually being as efficient as they can be, right? So lacrosse, right, they just have, for instance, they have healthier patients, and so they get more out of each dollar of healthcare spending, and so their health production frontier is just higher than Miami's is, right? So this is a picture, picture B, right? This picture here. Both Miami and lacrosse are being as efficient as they can be, right? You can quibble about, well, maybe Miami should, be here on their health production function, but they are both, in a sense, being as efficient as they can be, right? They're getting as much as they can. They're getting as much bang for they're given what they're spending. They're getting the best quality of care they can get. That's how we're defining efficiency here. And it's just that, for various reasons, the health production function for Miami is lower than the health production function for Wisconsin is. Now, why might Miami and lacrosse have different health production functions? Well, there are four main theories why. Right, so theory one, different input costs, right? So different costs of living, right? Maybe lacrosse, everything is cheaper in lacrosse and everything is more expensive in Miami. And maybe that explains why the health production function for Miami might be lower than the health production frontier for lacrosse's, right? So there are problems with that, though. Namely, adjusting for we can control for local prices, right? So there are data sets that look at local inflation and local prices in the US, right? You can get purchasing power, you can adjust incomes for, if you've heard of purchasing power adjustments, right? They're adjusting incomes for local prices, right? We have local price measures in the US, and after we adjust for those, it doesn't explain much variation at all. You still have these huge gaps in variation. And that still doesn't explain sort of why are some hospitals in LA twice as expensive as other hospitals, right? It doesn't explain sort of within regions where prices are fairly constant, right? Why overall, why are within cities, within states, are prices still so crazy, and why do they vary so much sort of at the local level? Because at the local level, in general, prices are pretty constant. So why the different places having different level of prices, and just things being more expensive in one area than another can't explain the differences we see at the local level. So it can't be differences in input costs, right? We can control for those, and it doesn't seem to have much effect. So what about, you might think it's different in hospital amenities. So there's more to so part of this is quality of care, right? But quality of care, right, that could explain different costs, but there's more to hospital amenities, right, than just quality of care, right? Amenities are sort of other bonuses, right? So it could be maybe one hospital is next to a highway, and so it's noisy, and there's trains going by it all the time, and so it's much less pleasant. The other hospital is much more pleasant. One hospital, they have those really harsh fluorescent lights. The other hospital, they have nice lamps with incandescent bulbs that are very soothing. I'm very light sensitive, which, if you can't tell from my love of incandescent bulbs and my visceral hatred of fluorescent lights and LEDs. Maybe one hospital, the beds are comfier, and that's not going to make a difference in living or dying, but it's maybe Miami has luxury hospitals, and lacrosse has Spartan hospitals that get the job done. They're just as good in terms of outcomes, but the Miami hospitals they're like hospital resorts, right? The problem with that theory is that there's really not much correlation between higher levels of patient satisfaction and higher healthcare, right? You'd expect that if a region had high healthcare costs because their hospitals were really resort hospitals, that patients would be thrilled to be at the resort hospital, and we just don't see that, right? Patients report similar levels of comfort and satisfaction with their care in places with expensive hospitals as we see in places with cheap hospitals. So it doesn't seem to be differences in hospital luxuriousness or other hospital amenities. So theory 3, different medical malpractice environments, right? So we talked about this earlier, where there's a real cost to allowing for medical suits. So if it's easier to sue hospitals and get money out of them, hospitals may pass the cost of those lawsuits along to patients. Now, the problem with this theory is that it cannot explain variation within states that have the same malpractice codes, right? So first of all, right, it can't explain the difference in, within LA, right? It's equally easy to sue all hospitals in LA, probably, or close to it, right? There's no way that explains the why the cheapest hospital in LA is twice as cheap as the most expensive hospital in LA is, right? And it can't explain, right? So there are regions that have very similar malpractice codes, and so this can't explain, right? If New York and New Jersey have the same medical malpractice laws, but the hospitals in New Jersey are more expensive, then malpractice isn't a good explanation for why malpractice suits are probably not a good explanation for why medical care in New York is cheaper than medical care in New Jersey is. For the record, I don't know if medical care in New York is cheaper than medical care in New Jersey is. Don't quote me on that. I suspect the opposite is true, but don't quote me on that. Then the last theory is that there are differing levels of illness severity between places. So, and something to remember about this study that I don't think I mentioned earlier, but it's worth keeping in the back of your mind, right? They're controlling for diagnosis here, right? So they're saying we're going to compare the cost of treating diabetics in La Crosse with the cost of treating diabetics in Miami. But even controlling for diagnosis, it could be that the diabetics in Miami are less healthy than the diabetics in La Crosse are. So even though they have the same diagnosis, maybe the diabetics in Miami, maybe their diabetes is worse. Maybe they're less healthy along other dimensions. Like maybe a diabetic in Miami is also more likely to have lung cancer, right? And so if there's worse health in a region, you're going to need to spend more on medical care to offset those health costs. And that could be another reason why Miami might have a lower health production frontier than La Crosse does, because people in Miami are less healthy than people in La Crosse are. Now, there is definitely evidence for this. This definitely seems to be true, and the researchers in the Dartmouth Medical Atlas definitely find evidence of this. However, even though there's evidence this occurs, it, combined with all the other theories, still cannot explain a satisfactory amount of regional price variation. There's something else going on even after you control for all these theories, right? So what do the Dartmouth Atlas researchers think happened? Well, they think, first of all, Miami does probably have a lower health production frontier than La Crosse does, right? So they think that if this is La Crosse's health production frontier, Miami's health production frontier is probably worse, right? They do think, yes, people in Miami are probably less healthy than people in La Crosse's, even conditional on their diagnosis, right? Diabetics in Miami are probably less healthy than diabetics in La Crosse are. However, they also think it's true that even given the lower frontier, right, even given the lower health production frontier, Miami is still lower than it should be, right? Where Miami is inefficient, even given its lower frontier. Where Miami is being wasteful, even though if it were being efficient, it would be spending more on healthcare. So what do they think is going on? They blame this on supply-sensitive care. Now, what is supply-sensitive care? Supply-sensitive care is health services whose use greatly depends on the supply of the availability of that care, right? So this is very, very similar to physician moral hazard, right? So examples of supply-sensitive care. A doctor who owns an MRI machine and has one on hand may be more likely to prescribe MRI treatments, right? Another example are hospitalizations, right? This is another. I'm always happy when I get to complain about UChicago Hospital. So let's compare the difference between UChicago hospitals, the UChicago Hospital, and the Northwestern Hospital, right? UChicago Hospital is always overcrowded. There's never enough beds. So you can have a pretty severe medical condition, and they'll send you home, right? They'll only keep you overnight if they really need you to. Now, Northwestern, right? They kept I went to the hospital with somebody very, very close to me. And back when I was in Chicago. And she was sick and turned out to be quite sick. And Northwestern, they not only found a bed for her, but they had plenty of beds to go around. So they were like, sure, spend the night, right? And so they found a bed for her. They got me when they saw me sleeping on the floor, they got me a reclining chair, right? Right, so hospitalizations are another example where supply sensitive care comes in, where if a hospital has more beds, like UChicago never has any extra beds. So if you spend the night overnight at the UChicago hospital, you're in awful shape. Northwestern has more beds available, and so Northwestern is more likely to let you spend the night if your case isn't as urgent, right? So that's another example of supply sensitive care. And the line between supply sensitive care and moral hazard is really thin, right? It's not always possible to distinguish between the two. And so the hypothesis of the Dartmouth Atlas researchers was that supply sensitive care / moral hazard is what's driving the differences in healthcare costs between places like Miami and La Crosse. And so if they're right about that, doctors with greater access to resources will overprescribe care. And their evidence for that is this graph here, which is a really interesting graph. So you'll notice, ignore the hip fractures for now. In general, there are more hospital discharges per medical care enrollee, right? So that means medical care enrollees are more likely to spend time in the hospital. Medicare enrollees are more likely to spend time in the hospital the more hospital beds are available. So in general, the more beds are available in a hospital, the more likely they are to have you spend the night. However, that's true for all medical care conditions. That is not true for hip fractures. Now, why is there no correlation for hip fractures? Well, it turns out there are, for many diseases, doctors have a lot of leeway about what to do, right? There's lots of ways to treat cancer, for instance, depending on the type of cancer, or there might be many ways to treat migraines, for instance. There's lots of different ways to treat migraines, lots of medications, lots of changes in health, in lifestyle, right? All sorts of things you can do to treat migraines. And so you can't really, but there's only really one way. There's a standard way to treat a hip fracture that everybody does. So there's no moral hazard in hip fractures, right? A hip fracture needs to be treated, and they're all treated the same way, no matter where you are. And so if there's no moral, so in the thing where we know there's no moral hazard, right? There's no moral hazard in hip fractures because the treatment is the same everywhere. There's no relationship between hospitalizations and the number of free hospital beds. However, overall, for most medical care conditions where there may be moral hazard, we see a very strong connection between those two, right? So this is evidence of supply-sensitive care, where for a treatment with a fixed for a condition with a fixed treatment like hip fractures, we see no difference in as hospital beds become more available. There's no difference in hospitalizations due to hip fractures. However, for most medical care conditions, there is a connection between those two numbers. So when basically the way to think about this is when doctors can prescribe more treatment, they do prescribe more treatment, right? When they have the ability to charge your insurance company more money. And right, if the hospital's already full, right, they'll send you away. But if they have a free hospital bed, they'll be like, oh, sure, spend the night, get a few more tests. You may not need the tests, but you're not paying for them. I'm not paying for them. The insurance company is paying for them. So yeah, spend the night, get a few more tests. We'll bill the insurance company. Don't worry about it, right? That's a form of moral hazard, right? Where they're ordering, it can be a form of moral hazard. It often is a form of moral hazard, where that moral hazard is increasing. The moral hazard increases the more free beds they have. Now, why may it not be? Why may it not be moral hazard? Well, let's say UChicago's case, right, where again, someone very, very close to me got super sick, right? Was worried she had a chemical burn, right? One of these biochemists I keep talking about. Basically, was worried that she had had a chemical burn in her lung. And UChicago was too busy to see her, right? Now, most hospitals would freak out if a patient came in saying, "Hey, I work in a chemistry lab and I'm having trouble breathing." That's like rush that person to the ER immediately. Not at UChicago. And that's because at UChicago they were like, "I'm sorry, ma'am, we just had 6 people who were shot brought in." That did happen one time I went to Chicago, which is why I don't remember what time it happened when I went to the UChicago ER, but I remember one time I went to the UChicago ER and I asked, are you going to be able to see me? And they said, "Oh, well, there was a mass shooting downtown, not downtown, on the south side, where 6 people were shot, and we're the trauma center for the south side of Chicago. And so you're not going to be like we're treating 6 gunshot wounds right now. We do not have the capacity to see you, rich boy." And and I was like, "Okay, got it. I'll go home." And I again, that was actually another case where I probably should have been hospitalized. I was super sick. I probably had COVID before. I think that was when I went in and I probably had COVID, right? But both me and this woman who I was very close to should have been hospitalized when we went to the UChicago hospital. That wasn't a case of moral hazard. That was a case of UChicago not having enough beds. Right? But if you don't have enough beds, you can only take the most extreme cases, and so you can't do moral hazard. Maybe you would like to do moral hazard, but you only can do moral hazard if you have free hospital beds. Again, the more free hospital beds you have, like Northwestern has more leeway to commit moral hazard than UChicago does, because UChicago is always overwhelmed, and Northwestern often has capacity. And so Northwestern may keep people for longer than they otherwise need to be kept, because Northwestern has more medical resources. And so, the conclusion of the Dartmouth Healthcare Atlas Project was basically they're with Dr. Cox, which is from Scrubs, which is, we're wasting a lot of money on medical care in the U.S. We're spending a lot of money on marginal treatments that don't make a lot of difference. So, what should your takeaways be from this lecture? The first is, despite evidence of overuse, the returns to medical technology have been high, right? So, price of right? So our health is improving. We have all these miraculous cures. We've had an immense amount of innovation in the medical industry, and even though there may be overuse of it, we may actually have too much innovation because of moral hazard. The returns are still super high. And 2 things are true at the same time. Health technology is improving and can be very impactful, and there are still many wasteful drugs and procedures on the market. And the last thing I'm going to close on, because I want to emphasize this, is the price of health is not the same as the price of health care, right? Remember and that can be hard to measure, but remember the price of a heart attack went up by a lot. Went up by something like 30%. That math, don't check my math. That's off the top of my head. From I think 1984 to 1991. However, the price of recovering from a heart attack dropped by 5%. By 0.5% a year, about 3.9% or either 3.4 or 3.9% over that full time period. Once you account for the increased life expectancy, right? So cost of health, not the same as the price of health care, right? I will leave you with that. And on that note, we are next going to talk about how do we assess the price of health and the price of health care, and how do governments and insurance companies prevent moral hazard and figure out which treatments are actually the most cost effective. Right? How do we figure out when somebody is below their health production frontier, and how do we tell when they're too far along their health production frontier, right? How do we tell when, someone's health production frontier looks like this? How do we tell they're over here and they really should be over here? How do we tell that? And how do we tell, they're over here and they really should be, over here, right? So next lecture, we're going to talk about health technology assessment, which is one of the most controversial subjects in health economics. And it is side note, next lecture is going to be one of those lectures where if you want to give a parody of evil economists, just show next lecture to your friends, and you'll soon be talking about the value of a statistical life and talking about how economists put a monetary value on life.